Live. Hello, guys. We're starting today's session on. This is the second session of our teacher and students session. And what we're going to do first, before I start off with the lectures, I'm going to talk about exam patterns of questions asked. And what we're going to do first, before I start off with the lectures, I'm going to talk about exam patterns of questions. Sorry, that was actually my own YouTube channel. Actually, you could hear that. So the first type of questions are open-ended questions. Like, for example, write a note on TRALI. And now this is open-ended. You actually have to have a set pattern to actually answer such questions so that you don't struggle in the exams. And then there are short answer questions, the old types, which would actually just split that into a few points, like define what is transfusion-related acute injury, or discuss its pathogenesis, presentation, and management. And later on, they started actually giving percentage to each question. So it was like define transfusion-related acute injury, 30% marks, discuss its pathogenesis, 30% marks, what is presentation of TRALI, 20% mask, and how is TRALI managed, 20% mask. So there was a division. So you knew how much amount of stress you need to actually have on each of these bits of the question. Now, the exams are changing. They are actually moving to something called constructed response questions, or CRQs. And this is an example given by the Royal College. It's the CRQ on management of severe asthma, a critical incident. And this is how the questions will actually go. It says list 3 possible physiological changes in the lungs seen in asthma. And this is 3 marks. That means you need to actually give the 3 answers, 3 bits. So you miss out on anything, you actually lose the marks. Then they have a description of a case. Is a 57-year-old female who is known to have asthma, is having a laparoscopic cholecystectomy under general anesthesia with endotracheal intubation. Uh, and it says, interpret her preoperative pulmonary function test shown below. This is 2 marks. Age of the patient 57, weight 62 kgs, height of 165 centimeters. And then they give you this values of FE1, FEC, FE1 by FEC, and you need to be able to actually do the interpretation for these cases. Then C is the list 6 factors that may cause her to develop bronchospasm during a general anesthesia. And then you actually have to list that 6 things, and that 6 things should somehow match the list which the examiners have been given. And then last one is just 5 marks. Says she does develop acute severe bronchospasm. What drugs, including dosage? Now it says here, specifically says dosage, so it's not just mentioning the drugs. You have to mention the dosage as well, were applicable and can be used to treat this. So this is 20 marks questions, and you have to, at least very specific. So these are CRQs. And the last one is list 4 other actions you could take in the early management of this emergency. So the examinations are actually becoming a little bit tougher. So if you do not actually have full knowledge of this condition, then you will not be able to answer these questions. Now, coming to today's sessions, we have 6 questions. The first question is on hematology. It's about transfusion-related reactions. The second one is on pediatrics, is a foreign body inhalation. Third one is on venous air embolism. Then we have some basic sciences on lasers and anatomy and regional anesthesia of lumbar plexus. And then chronic pain question on neurogenic pain. Okay. So here we start off with the first one. This is on transfusion medicine. So the question is, define transfusion-related acute lung injury, TRALI. Discuss its pathogenesis. How does TRALI present and how is it managed? How can TRALI be prevented and what are the outcomes after TRALI? So quite a few questions within this. Okay, so now between 2004 and 2019, TRALI was classified into TRALI and possible TRALI. And from 2019 onwards, that is since last year, it's now classified into type 1 and type 2. Okay. So this is TRALI as defined by the Consensus Conference Committee 2004 and European Hemovigilance Network. So TRALI is an acute respiratory distress. Okay, so ALI is acute lung injury. So this causes acute respiratory distress, and it presents with bilateral lung infiltrations in the chest radiograph or the X-ray, and it occurs during or within 6 hours after completion of a transfusion. Okay. There is no evidence of transfusion-associated circulatory overload, so this is not TACO. And this is not cardiogenic pulmonary edema either. So this has to be, should not be part of the your definition. The patients present with hypoxemia, where it is defined as PO2 by FiO2 ratio of less than 300 millimeters of mercury, or oxygen saturation of less than 90%, or other clinical evidences of the low oxygen saturation. New acute lung injury and no other acute lung injury risk factors are present in these cases. So things like it should not be secondary to aspiration or multiple trauma, pneumonia, cardiopulmonary bypass, burn injury, toxic inhalation, lung contusion, pancreatitis, drug overdose, near drowning, shock, or severe sepsis. These should not be present. This should not be the cause. Okay. Now, if one or more than one acute lung injury risk factors are present, that is as outlined before, then it is termed as possible TRALI. Okay, so it's not TRALI, but it is possible TRALI. Okay, So this is from 2004 till 2019. So this is the old definition. Now in the new definition, that is after following the 2019 consensus. So type 1 is similar to 2004 definition. So in this, the first one, or factor A, is no risk factors for ARDS, and all the following criteria are met. So this is an acute lung injury, which is or acute respiratory distress, which is acute in onset. There is hypoxemia, so this is defined as PaO2 FiO2 less than 300 millimeters mercury, or SpO2 less than 90% on room air. Okay, not on oxygen, but on room air. And there is clear evidence of bilateral pulmonary edema on chest X-ray. There is no evidence of left atrial hypertension, or if left atrial hypertension is present, it is just to be the main contributor to the hypoxemia, not the main contributor to the hypoxemia. So there is no cardiogenic pulmonary edema in this case. And onset during or within 6 hours of transfusion. So this is the same as your 2004 definition. And the third thing is there's no temporal relationship to an alternative risk factors for ARDS, which was defined in 2004 definition, where the risk factors for ARDS were ruled out. And if they were actually present, one of the risk factors are present, then it used to become a possible TRALI. But here in the new definition, there's no possible TRALI. So it's now called type 2 TRALI, and so risk factors for ARDS are present in type 2. So instead of possible TRALI, now it is called type 2. But ARDS has not been diagnosed, or it is mild ARDS at baseline with respiratory status deterioration. That is just to be due to transfusion. So there is transfusion. There are risk factors present for ARDS, but it's not a full-blown ARDS. And then you give transfusion and things deteriorate. Okay, so patient goes into acute respiratory distress. You see changes on the chest X-ray. Okay, and there is no evidence of increase the left atrial hypertension. And the patient should have been stable, have respiratory stability or stable respiratory status in the 2 hours before the transfusion. So there wasn't any acute respiratory distress, though there might have been risk factor. There was no acute respiratory distress in the previous 12 hours before the transfusion. The patient deteriorated within the 6 hours of transfusion, and there were some risk factors present. So this is type 2 TRALI. Okay. So this is to do with definitions. So if you look at it, the definitions from possible TRALI has now changed to type 2 TRALI. That's it. Otherwise, definitions, there are not much different. So they've taken off the possible TRALI, possible from the TRALI tag. Okay. So pathogenesis, there is actually quite a lot of emphasis on two-hit theory. But pathogenesis can be classified into immune or non-immune theories as well. So what exactly is a two-hit theory? Okay. So the first hit in this two-hit, the patient actually has got certain risk factors. Okay. So patient has sepsis or has got history of hematological malignancy, has had cardiopulmonary bypass or heart surgery, has been mechanically ventilated for whatever reason. There is history of massive blood transfusion. Patient has history of chronic alcohol abuse. Patient is in old age. Patient may be in shock or acute renal failure. There is history of severe liver disease. Patient has had a spine surgery. Okay, this is which is usually associated with massive blood transfusion or liver surgery. Again, where there is a large amount of transfusion. Now, this first is basically are leading to priming of the neutrophils, okay, for activation. So the second hit occurs because of the transfusion factors. So there is HLA or HNA, that is human leukocyte antibodies or human neutrophil antibodies or bioactive lipids or the CD4Ls. Old erythrocytes has been one of the factors. Transfusion of the FFP and platelets. So it's usually related with blood products rather than RBCs. But RBCs may actually contain certain factors that can actually lead to activation of the primed neutrophil. So there's already priming of neutrophil from the first hit, and the second hit, there is then activation. Okay. So if you can look at it, this can be that there are transfusion-related factors, there are recipient-related factors, and there is a balance between potential multipliers and potential attenuators. So potential multipliers here are monocytes, platelets, and complements, whereas the attenuators are the T lymphocyte and red blood cells. Okay. So what normally happens is that antibodies are present in the transfused blood components. And like I've said, this is the HLA or HNA antibodies. And these, these antibodies, they activate the neutrophils or monocytes. Okay. So when it activates neutrophils directly, they release mediators. Whereas when they are attached to the monocytes actually then causes activation of the your neutrophils. Okay, so it doesn't happen directly. Okay. Then there's obviously the platelets. The neutrophils activate the neutrophils and they release these mediators. I'll talk about these mediators in a minute. Okay. And in certain cases, the HLA class 1 antibodies, they bind to the endothelium of the lungs directly. Okay. And there can also be anti-HNA3 antibodies, which can again activate the neutrophils and release mediators. There might be mediators present within the cellular blood components, which are not very strong. They themselves cannot actually cause release of the mediators from the neutrophils, but acting together. Okay, so this bioactive lipids or CD440L, and these are actually derived from cellular blood components, which can, stimulate the neutrophils, but they're not themselves very strong factors. So in the presence of the other factors, they would actually cause release of the mediators. Okay. So if you actually look at the overall pathophysiology of TRALI, there is basically neutrophil priming, and then there is neutrophil activation. And this leads to the neutrophil aggregation, margination, and sequestration in the lung microvasculature, which leads to leakiness of the endothelium. And that's what actually causes the kind of pulmonary edema kind of picture on the chest X-ray. Okay. So the agents which causes priming and activation, I have already described about the anti-nuclear antibodies or the lipids and the chemokines, cytokines. So when these are activated, the priming occurs and there is activation of neutrophil. They release reactive oxygen species, elastases, proteases, and these actually cause the endothelium to leak. There is also interleukin 1 beta and intracellular adhesion molecule 1, ICAM1, helps in addition and aggregation of the neutrophils to the endothelium. Elastase proteases causes the leakiness. Okay, so these all are actually happening. So, but if you have to define it in a very simple terms, there is priming followed by activation of the neutrophils. There can be direct activation of the endothelium as well by the antibodies present in the blood products. So I think these 2-3 words you actually have to use in your answers. So there is priming, of the neutrophils or monocytes. Actually, monocytes that can also be activated or primed. And ultimately, there is activation of neutrophils, which releases these very reactive substances like reactive oxygen species, elastases, proteases, as well as interleukin 1 beta and ICAM1, which causes aggregation, margination, sequestration of these neutrophils in the lung microvasculature and leakiness. Okay. So, how do we diagnose TRALI? Okay. So TRALI should be considered in patients who develop hypoxemic respiratory distress during or within 6 hours after transfusion of any blood products. Okay, so that's the diagnosis. So patient usually present with sudden onset of hypoxemia and respiratory insufficiency. Like I said, it is happening during or shortly after transfusion of blood products, so FFP platelets, okay, plasma. And patients who are intubated can actually have frothy airway secretions, like just like pulmonary edema. They present like with pulmonary edema. They can have fever, cyanosis, and can present with hypotension. So, what is the differential diagnosis for TRALI? So, other conditions which leads to respiratory distress following transfusion can be other, differential diagnosis. Also, you need to also think of TACO. Okay, there's a fluid overload in the TACO. You should also think of other causes of acute lung injury or ARDS, that's acute lung injury. So possible TRALI or transfused ARDS was the old term which were used. Okay, so and those should also be kept in mind. What is the management of TRALI? Obviously, you would actually stop the transfusion of the blood products, but most of the time they probably have already gone in, so there's nothing much you can actually do. You need to evaluate the patient. So if the patient is actually not intubated, might require intubation. You need to assess the degree of hypoxemia, so blood gases. And while you are actually doing all this, you can order a chest X-ray, and that will likely give you a diagnosis of the infiltrates on the chest. In the meanwhile, it's just supportive management. So airway, breathing, circulation need to be supported. You need to give oxygen. You might require to intubate and ventilate the patient. Steroids can be used. Diuretics have very little role in this. Okay, this is not a fluid overload. This is a leakiness of the endothelium, like I've said. So diuretics, you might actually want to keep them a bit dry, but it's not something which is part of the treatment. It's basically supportive treatment. Can TRALI be prevented? Yes, there has been a move towards trying to reduce the incidence of TRALI. So the first thing is that donors who have had history of TRALI, their donation are not accepted. Okay. Donations from multiparous women, again, are actually considered to be one of the factors for TRALI. So these donations are prevented for them. So supplying transfused blood plasma products like plasma, platelets, whole blood exclusively or predominantly from male donors, female donors with no prior pregnancy, and donors who test negative for HLA antibodies, HLA or HNA, hemoleukocyte and human neutrophil antibodies. Okay, so they should be test negative. So I think following this, the incidence of TRALI has been actually reduced markedly in patients. Okay. Outcomes are actually pretty good. 80% improve within 48 to 96 hours with prompt treatment. So if you diagnose and support them, and that is in most cases, patient will just require is a increase of 502. Very 70%, 3/4 of patients may require short-term ventilation. Usually, no permanent pulmonary sequelae are seen in these patients. The deaths mostly occurs from the complication related to pulmonary insult. So either it's a superadded infection or the ventilation related injuries to the lung is probably the main cause for the complication in this. Okay, so most will recover completely. Okay, so that was the question on TRALI. The next question is a lot more clinical. It's about pediatrics, foreign body. The question is outline your anesthetic management of a 2-year-old child who is scheduled for therapeutic bronchoscopy following inhalation of a foreign body 2 days ago. The child is fortunately does not exhibit any signs of upper airway obstruction, so that's a good thing. So how do you manage this patient? So management should always include these aspects. So we should have history and examination, investigation. There should be something on pre-medication. And then we talk about anesthetic technique, complication, and post-operative management. So any case where management are actually asked, these components should be present in your answer sheet. So for specifically for this 2-year-old child, history and examination, we need to take history from parents, see what is a likely kind of foreign body. Is this organic or inorganic foreign body? Because that makes a lot of difference. If it's a organic foreign body, it can swell up and cause further distress. Look for symptoms. Has been patient been having cough or has been bringing out any sputum, and then we obviously take other history of medical history, drug history, social history, etc., relevant to the patient. You'll obviously examine the chest. You'll auscultate, take core temperature to make sure there is no signs of infection, systemic infection, and a chest X-ray. You will normally look for it, and there is usually unilateral hyperinflation. And if possible, if you can take an explorative film, then that'll be great. Sometimes the foreign body, especially if it is an inorganic foreign body, metal foreign bodies, they can be actually seen on the X-ray. On the full blood count, you would actually like to see if there is an increase in the white cell counts, because that would actually suggest if there is any superadded infection, because this is two days old. So this is not an acute, but this is a 2 days old foreign body. Okay. So like I said, on the chest X-ray, you normally actually see hyperinflation on one side. Okay. So in this case, the foreign body has not been actually seen. So it's probably gone on to the left side of, to the right side of the chest. But in children, the bronchus takeoff is actually equal. So it can, unlike in adults where the right side is more common, in children, it can go to either side. Foreign body can go to either side. Pre-medication, you might think of atropine or glycopyrrolate orally to drive the secretion, amla or amitop on the hands, if you're planning to actually get a drip in. We would actually avoid giving any sedation, and so it is mostly psychological preparation, 2-year-old child. There's going to be a lot of separation anxiety in the child, so the parents are allowed in the anesthetic room. And the parents are explained, not the child, the parents are explained what is going to be done. A consent is taken from them, and the child is going to be, anesthesia is going to be induced in their lap. So they should be, aware of what is going to happen in the anesthetic room. Also important is that we may not actually know the weight of the child, though it can be, taken. The weight can, if the child allows, you can take that. But if it's not, then you should know some of these formulae. The weight estimated age for this child will 2 times the age plus 4. So this is 2 years old, 2 plus 6, so 6 into 2. So approximate weight for this child is around 12 kilos. So this is good for examinations. So in the examination, you can't actually say, oh, I'll weigh the child, but you can actually write. So this time it says the expected weight is 12 years. So this could be a Viva question as well. So short your Viva, short cases. Then endotracheal tube size. Nowadays, we actually are using cuff tubes as well. So For cuff tube, it is age by 4 plus 3.5. So this is 2 years old child. So it'll be 4 millimeters cuff tube, or age by 4 plus 4.4 or 4.5, or age plus 16 plus age by 4 in millimeters will likely give you the size of the uncuffed tube. And the depth of the tube should be age by 2 plus 12. So this is 2 years old, so around 13 centimeters, or whatever is your the endotracheal tube size into 3. Okay, so I think this is to do with uncuffed tube, I think. So size is 4 into 3, 12, 12 plus 1 and 13. So around 12 or 13 centimeters. So nothing much beyond that. So like I said, this is a 2-year-old child. And so we assume that the weight of the child is 12 kgs and the reticular size will be 4.5 uncuffed, 4 millimeters cuff tube. We need to ensure that we have a skilled assistance, all the equipment is checked. And as far as induction is concerned, there is nothing right or wrong. You can actually do inhalation induction, but if you manage to get a IV cannula, then you can actually do IV induction as well. Do we give muscle relaxation or not? Again, that is some people believe that you can actually give muscle relaxation. It makes things easier for inserting the bronchoscopes. Others would actually just say, let's go for topical lignocaine and leave the patient breathing spontaneously. Because muscle relaxation, you may actually say that this can actually lead to the dislodgement of the foreign bodies and moving it further down. And again, some would actually secure the airway, make sure everything is fine, and then hand over the airway to the surgeons, where then they will likely put in a scope. Okay. So some, like I said, can just deepen the anesthesia if not paralyzed. Sevoflurane actually works very well. You can intubate patient with sevoflurane. 2-year old child works fine. You're monitoring everything. So SpO2 is obviously important. And most of the bronchoscopes nowadays come with a ventilating side arm. And this allows for IPV or spontaneous ventilation. At the same time, this gives good visualization as well. And it allows for a forceps to be placed to get the foreign body out. Okay. Sometimes the foreign body is large, then it is actually grasped and the whole thing comes out along with your bronchoscopes. So these are ventilating bronchoscopes, and you can actually see that you can actually attach a breathing system, whether you want to use a circle system or you want to use STPs. You can use it either way. And you can actually see that there is actually port for the forceps as well as for the telescope. And you can actually continue ventilating the patient. So it gives you the flexibility of actually having patient, because children tend to desaturate very, very rapidly when you take out the ventricular tube. So maintaining oxygenation and anesthesia is actually easier with this ventilating scopes. What are the complications intraoperatively? If you are not actually paralyzed, then there are chances of breath holding. Sometimes there might be desaturation happening because if you're not able to ventilate the child appropriately. In that case, you might ask the surgeon to just take out the bronchoscope, go back on the mask ventilation, or you might have to put an endotracheal tube. Hypercapnia should not be a problem, but then with certain inhalation agents on the older time, we used to use halothane that causes a lot of dysrhythmias. Neuro agents, you don't see them as much. And in the postoperative period, there can be risk of laryngospasm and hypoxia can happen because of the edema, because of the the child's airway been a little bit more prone to they are susceptible to laryngospasm, children anyway. Stridor again, so these complications should be kept in mind. And therefore, in the postoperative period, after the scope is removed, we tend to reintubate the child and extubate them when they're a little bit more awake. We make sure the child gets Humidified oxygen through a head box or mask or nasal prong if they can actually accept it, and you continue to monitor the oxygen. It's not uncommon to actually give nebulized dexamethasone or IV dexamethasone as well, or nebulized epinephrine to reduce the edema from the airway. Antibiotics are usually given if there is actually any suspicion of infection, and especially if the foreign bodies are organic foreign bodies like inhaled peanuts. Now, peanut has this, if this has been for 2 days in the airway, and then it's going to swell up, and when they're taking out piecemeal, it just breaks down. Okay. And if you have not paralyzed and used local anesthetic spray, then make sure that child is then kept nil by mouth orally for at least 3 hours, because the airway, the vocal cords are insensate, so they can risk the chance of aspirations. All rightly there. Okay. Coming to our third question is on venous air embolism. It says outline the diagnosis and management of massive venous air embolism. Okay. And when you say massive venous air embolism, then you need to know the definition of what exactly is massive venous air embolism. So a volume of 1.5 to 4 ml per kilo. So in an average person is a 70 kg man, so 100 to 280 mLs of air would be considered a massive air embolism. But more than the volume, it is the rate of the venous air embolism that is important. So air embolism of more than 0.5 ml per kg per minute, or more than 35 ml per minute in a 70 kg man, that can cause disaster. Okay. So venous air embolism is a potential complication of many of the operations. And what predisposes this is the gravity. So if the patient is actually head up and the CVP is low, so the veins are actually open in the neck or in the anything above the heart. So that can poor surgical techniques where the venous system is left open to the air. Okay, and it may be unexpected. And the successful outcome depends upon the diagnosis and immediately managing the venous air embolism. Whether patient has a cardiorespiratory arrest, then how you manage them, or how do you suck out the air, and those are all very, very important. Okay. So diagnosis is always we need to have high degree of suspicion, especially when patients are in a sitting up position or where the operating field is above the heart level. So it has been seen that the incidence is around 25% in patients where the dural pressure at 60 degrees is almost 6 centimeters, minus 6 centimeters of water, and 90 degrees is minus 13 centimeters of water. So incidence is pretty high in a sitting up position, and that's why nowadays very few surgeries actually done in sitting up position. But it's quite possible even things like ENT procedures, they might want the patient to be sat up a bit. It can happen even laparoscopic procedures where they like to have patients head up and tilted to the left. So these cases, it can happen even in surgeries like mastectomy, scalp reflection, head and neck surgeries where there is large area of tissues that are exposed. It can happen in surgeries where there is gas injection under pressure, like laparoscopic cholecystectomy, hysterectomy, nephrectomy. It can happen where there is cementing in orthopedic procedures. Now, cement causes exothermic reaction, and we all know gas expands with temperature. So the canal can get highly pressurized, and even a small bubble can actually, enlarge in size and get into the circulation cause. It can happen in the cardiopulmonary bypass, whereas the externalization of circuit happens. Okay. Then it can happen in pregnancy, especially in termination of pregnancies, where the sinuses can be open, or manual removal of placenta. Okay, again, where the sinus remain open. So in these cases can happen. So there is a chart. So you can classify them into surgical procedures, the risk factor surgical procedures. So neurosurgery, like craniotomy shunt operation, ENT procedures, orthopedic procedures, arthroscopy, or even cementing, obs and gynae, like hysteroscopic, laparoscopic, cesarean section. Like I said, they also termination of pregnancy and manual removal of placenta, cardiothoracic surgery, bypass, in lung resections, places where laser resection is done because laser produces heat, in case of lung transplantation or needle biopsies. It can be related to intravenous catheterization, central lines, hemodialysis lines, CABG, angioplasties, pacemaker defibrillar placement, radiofrequency cardiac ablations. These are radiological procedures like intravenous contrast injection, arthrograms. They are associated. It can happen in trauma and head and neck injuries, penetrating and blunt chest injuries. Uh, Blunt abdominal trauma can also lead to embolization. It can happen in positive pressure ventilation. Well, we need to have a communication with the venous system. And the other cause is decompression sickness, where there is rapid descent, or sorry, ascent, not descent, ascent, where the bubbles can go into the circulation, cause bends. Okay, so that's also, yeah. So how does venous air embolism present? Obviously, the air has gone into the right side of the circulation, so CVP and pulmonary vascular resistance will increase. And because this will reduces the flow through the pulmonary circulation, so there is a reduction in the left atrial filling pressures. And similarly, there will decrease in the left ventricular filling pressures. And this will lead to a reduction in the cardiac output and fall in blood pressure. Now, clinically, mill-wheel murmur can be heard. I have actually heard it once, and this happens in massive venous air embolism, where the embolization is of 1.5 to 4 ml per kg body weight. You can get lots of ectopics. Ventricular ectopics are common, and if the air goes into the pulmonary circulation, there can be airlock and cardiac arrest. So the clinical signs are normally seen when the air embolization occurs at the rate of 0.5 ml per kg per minute, or that is around 35 mLs per minute, in an average 70 kg man. So that's when you normally see the clinical signs. Okay. We also need to be aware of patent from an ovale, okay, so which is present in 25% of adults. In these cases, the air can move from the right side to the left side of the circulation and bypassing the pulmonary circulation. And if this happens, you just need a gradient, increase in gradient of 5 millimeters of mercury. Also, when the pulmonary artery pressures actually go, so when the air goes into pulmonary circulation, that will also increase the right-sided pressure, and this can lead to opening of the pedant from an ovale and the air moving from the right side to the left side of the circulation. Okay. So the monitors for monitoring venous air embolism, they need to be high level of sensitivity and very good specificity, and they should be rapidly responsive. And it should be able to quantitatively tell us the amount of air embolism, and maybe give some indication of how the course of recovery is going to be. So can we actually observe the improvement in the parameters? So if you look at all this, then precordial Doppler and end-tidal CO2 monitoring are the two things which probably fulfill the criteria for these. So if you look at this graph, and the x-axis, we have the sensitivity. So decreasing sensitivity, not increasing, decreasing sensitivity. And on the y-axis, we have the venous air embolism, the rate oblique volume. And we can see that transthoracic echo or transesophageal echo, they are actually very, very sensitive. But then they can actually also diagnose things which normally, small particles going into the circulation, as that. Doppler is, like I said, Doppler and tidal CO2. These are two monitoring which fulfill the criteria. So they have kind of a good sensitivity and specificity. And they can diagnose the venous air embolism before the clinically apparent changes occur. So if you look at the cardiac output and CVP monitoring or changes in the blood pressure ECG or a Millville murmur, by that time the cardiovascular collapses have probably happened. Okay. Whereas when there are increase in pulmonary pressure or internal CO2, they're only modest physiological changes. So the early changes are actually seen in that. So the greatest sensitivity is seen by transthoracic or transesophageal echocardiogram or precordial Doppler. So you can actually diagnose air from anywhere from 0.15 to 0.30 ml per kg body weight. Pulmonary pressure and total CO2 are intermediate, so you can diagnose around 0.6 to 0.23. Okay, so that's 0.6 to 0.63 ml per kg body weight. Whereas PCO2, mean arterial pressure, or transcutaneous carbon dioxide level are the least sensitive. By this time, the patient has probably already had a cardiovascular collapse. So they only become, changes occur when the embolization is up to around 1.1 to 1.5 ml per kg body weight. So that's a large, very huge amount of thing where the air trapping can happen and there can be cardiovascular collapse. How do we manage venous air embolism? This is one thing you need to do is prevent further entry of air. So you go inform the surgeon and say, well, my dear, stop operating now and flood the field with sodium chloride so that air doesn't go in. Whatever goes in is just there. Okay. They can also compress the wound site if feasible. And if you're using nitrous oxide, you need to stop using and give 100% oxygen at high flows so that you can wash out the nitrous oxide immediately. Nitrous oxide is 35 times more soluble than nitrogen, so it will expand pretty rapidly. You can apply PEEP and actually make sure that patients get fluid so that the venous pressures are actually on the higher side. To prevent embolization into the circulation, some people like to say you can do neck compression, but I think if it has gone through the python foramen ovale, you are not going to compress both eye and reduce the blood flow to the extent that the air can't go in. So that's, I think, a very meek point, but some people actually should actually press that. Then is management of the presentation of the intravascular air. So we need to minimize the cardiovascular impact of the air going in. So you're going to put the patient into the left lateral position with head down so that the air is trapped in the right ventricle. And if you are expert, you can actually put in a central line in and with multi-hole lumen and aspirate the air from circulation. And if you're actually placing a multi-orifice CVP line in cases which are high risk for venous embolism, the optimum position is considered to be at the junction of the SVC and the right atrium. Okay. And accurate positioning can be done with X-ray guidance or looking at the pressure changes. So obviously when the patient is already anesthetized and it's actually happening, in that case, X-ray is not a thing. But what you can do is when you're putting in a central line, make sure you attach it to a transducer and you keep looking at the waveforms. Okay. Or if you have intravascular ECG, make sure that you're able to actually do it under guidance. Okay. With intravascular ECG, there is always the risk of cardiac microshocks are there, but that is very minimal. It is one thing we just need to mention that's one of the risks, but it's very, very rare. It's very rare. With the present monitors, which actually use isolated power system, they hardly actually happen. Then, of course, is the cardiorespiratory support. You will make sure that cardiac output is maintained with fluids and vasopressors on trips. You will make sure the patient gets 100% oxygen. You'll continue to ventilate them with IPPV and PEEP. Okay, and this will also attenuate the pulmonary edema. So having the PEEP on will increase the venous pressures. Okay, because it's transmitted through the chest. So This will prevent further entrainment of air. Okay. Moving on to the fourth question on lasers. So what is a laser? How is laser used? What makes laser behave differently from one another? And what are the hazards associated with lasers? So lasers, this is another way of actually asking that question. So we're given 30% to the basics, okay, 30% to about how they made different, and 40% to the hazards. Okay, so that's another way of asking these questions. So laser is an acronym for light amplification by stimulated emission of radiation, and it itself actually describes what lasers are. So there is amplification by stimulation, okay, of emission of radiation. So let's look at what exactly is this. So when you have a stable atom and you actually apply energy to it in the forms of photon, and this excites the atom. And so the atom actually moves to a higher level. And when this energy actually taken off, it comes to a resting state, the stable atom will actually release a photon. That is before it comes back to the resting state. Now, if you actually stimulate it again before it comes back to its resting state, then you get two photons. So let's look at it in a different way. Okay. So you actually get this, the atom, which is actually at the resting level. You apply energy to it, and it will actually move to a higher level. Okay. So it's gone up to a higher energy level. And when you take away the area, then it actually comes down, and as it comes down, it releases a single photon. So this happens normally. But if you actually apply this energy when it's in midway, okay, that is before it comes back to the resting state, you apply energy again, then you actually get two photons which are in the same wavelength, so they are coherent, okay, to each other. Okay, I'll likely tell about the characteristics of these. Okay. So if you look at a laser, it consists of a tube, and this tube actually has got a fully reflected mirror on one side and partially, a reflective mirror, that is, it's got a hole for the laser beam on the other side. And this is filled up with a lasing media, and this lasing media can be gas, liquid, or solid. And then we need to have an energy source which will activate the atoms. Okay, so this energy can be supplied via the electrical discharge tube, flash tube, and it can be another laser. So it is about exciting the atoms and then hitting them again before they come back to the resting position. So that's how lasers are produced. Okay. So like I said, these photons which are released, they are coherent. That is, all waves are in phase, both in space and time. And they're collimated, and that is, they travel in parallel lines, so they can travel any distance. They do not meet, so they can keep traveling. And the waves are monochromatic, and they have the same wavelength, absolutely same wavelength. So these are the three terms, or three properties of the laser beams. So they are coherent, they are collimated, and they are monochromatic. Okay. The factors that determine the type of lasers is obviously the wavelength. Second thing is by the power density. So this is the energy delivered per unit area of cross section, which is measured in watt per centimeter square. So how much energy can they deliver at the point where they are supposed to act? So because these are coherent beams, they can be focused into small spots, and where you can have very high power density, and hence they can be used for cutting or vaporizing tissues. You can use lower power densities for coagulation. So lasers can be used for cutting, coagulation, vaporizing tissues. Okay. Now talking about vapors, so vaporizers and the lasing media, the way they are actually named, they are based on the lasing media. So laser, so it's called carbon dioxide laser because the lasing media is carbon dioxide, and it has a wavelength of 10,600 nanometers. So this is in the invisible or far infrared range. And carbon dioxide is absorbed by all tissues and water. So that's why it is used for general or precise surgical cutting. And then we have neodymium YAG. Okay, so this is yttrium aluminum garnet. YAG stands for yttrium aluminum garnet. So that is a solid phasing media. You can have neodymium YAG KTP. KTP stands for potassium tetanil phosphate. Again, that is, and you can actually see they have different wavelengths. So neodymium YAG is only 1064, whereas the neodymium YAG KTP is 532. And that emits emerald green light, and it is absorbed by blood. Now, whereas the neodymium YAG is in an invisible range, far infrared, and they are normally absorbed by the darkly pigmented tissue. Then we have argon, krypton. Okay, so there are various, again, different kind of laser based on their lasing media, and they use different wavelengths, so different absorptibility. So like if you look at argon and krypton, they are in the blue-red or blue-green range, so they are absorbed by melanin and hemoglobin, so used for pigmented tissue or the skin lesions. Okay. So what are the hazards? Hazards can be classified into hazards to the patient, hazard to the staff, hazard to the environment. So that's a small, simple classification, which is very useful. So in the environment, there can be atmospheric contamination, like lasers are used for treating, say, papillomas, which are full of virus. Okay, so they produce something called plume, and these, if they're absorbed, it can cause seeding of the papillomas into the stuff. Okay. For the patients, the tube can actually go on fire, so that's why you have special tubes. And you are not supposed to actually use any flammable material, or oxygen is used in the minimal FiO2. And we talked about embolization in the last lecture. In that one, anywhere even in the blood, it can cause bubbling and embolization. And if the surfaces are actually not matted, if they are shiny, they can actually bounce off that, and they can actually be transferred to anywhere, so it can cause injury to other people. And in the areas around which the laser is used, blood vessels or hollow viscous, they can cause perforations, and that's because of, again, inappropriate energy transfers there. So how do you prevent this in the environment? Make sure that you use suctions and filters. You make sure that there are actually laser boards across the doors, and the doors and windows are actually closed and have appropriate level of protection. For the patient, to prevent fire and explosion, we can use total intravenous anesthesia. So no oxygen used. Or so if you're using oxygen, then in that case, make sure use low FiO2, or use laser tubes, and equipment should be matted equipment. And for the staff, it's important that they all have training, and appropriate type of goggles are used. Goggles is a laser goggles, and laser tubes are our OSCE stations, and I'll talk about them sometime. Question 5 is on lumbar plexus. Says draw a diagram of lumbar plexus, outline the basis, anatomical basis of 3-in-1 block, and explain why the block may fail to provide reliable analgesia for hip surgeries. Okay, this is a simple diagram of the lumbar plexus. I will actually post a video of how I actually do it. The nerve roots for the lumbar plexus come from L1, L2, L3, L4. L4, L5 gives a branch to lumbosacral. The ventral divisions gives rise to the lateral cutaneous nerve of the thigh from L2, L3. L2, L3, 4 dorsal division give rise to femoral nerve, and the same one on the ventral side gives rise to obturator. Now, L1 divides into iliogonal, iliohypogastric nerve. Iliohypogastric nerve may gut also get a branch from T12. And L1, L2 forms the genitofemoral nerve. So even though iliohypogastric, ilioinguinal are not considered actually a part of lumbar plexus, but they are actually, because they get some components from L1, L2. Okay, so that is the lumbar plexus. Now, what is a 3-in-1 block? 3-in-1 block is basically a high volume block where you stimulate the femoral nerve and assume that the large volume will actually spread proximally. And this is also known as the perivascular approach to the lumbar plexus. And if you can actually see, the femoral nerve lies on the lateral side of the iliopsoas. The lateral cutaneous nerve thigh actually comes out of the psoas sheath midway through and lies between the fascia lata and fascia iliaca, whereas the your femoral nerve carries on below the fascia iliaca. Obturator nerve lies on the medial side. Okay, so that's it. So when we actually give, that's how the proximal spread occurs, and it usually occurs onto the lateral side, and that's why when local anesthetic is given, it tends to block the femoral and lateral cutaneous nerve thigh in most patients. Okay. You can use simple diagrams where you actually draw a circle and intercephalic spine on the lateral side, pubic tubercle, and the vein and artery in the femoral sheath and femoral nerve line. Or you can draw a little bit more advanced diagrams when you show the skin, fascia lata, fascia iliaca, femoral nerve lying under the fascia iliaca, lateral cutaneous nerve lying between the fascia lata and fascia iliaca. So this is basically the femoral nerve block with large volume. Okay. So this diagram is actually showing how the local anesthetic actually, or the nerves are blocked. So in the the obturator nerve is only blocked in 33% of the cases. So it's not a truly 3-in-1. This is mainly 2-in-1 block when you give large volume. To reach the origin of the lumbar plexus, you need to use volumes equivalent to almost the patient body weight. So if you have 60 kg person, then you need to use 50 to 60 ml of the volume to actually block all 3 nerves. Okay. And hence there is failure of obturator nerve. So why does 3-in-1 fail? So we need to understand dermatomes, myotomes. Also it should have been osteotomes. Say dermatomes here again. So in hip surgery, if you look at it, the hip at the dermatome level, you need to actually block the lateral cutaneous nerve. And for the muscles, you need not only femoral, you need obturator and you need sciatic. So obviously in 3-in-1, you are not blocking the sciatic, and obturator is only blocked in 33% of the cases. And hence, we don't get complete analgesia from the lumbosacral trunk. So this is actually showing the hip joint anteriorly. So you have the femoral and obturator anteriorly. And then you have the sciatic posteriorly. So osteotomes, again, are not covered completely. So the only thing you cover is the skin and maybe one part of the femoral nerve. Last question of the day, it is about listing. Okay, so this is not exactly a question on description, it's about list with examples of cause of neurogenic pain, what symptoms are produced, and what treatments are available. So you're not asking a specific syndrome, you're asking you to list the causes of that. So neurogenic pain is actually pain, any pain arising from the nervous system, whether it's a peripheral or central nervous system, is a neurogenic pain. So if you look at the peripheral neurogenic pain, it can happen following transient stretching of a peripheral nerve or root, or it can, when it becomes sustained, then it can actually lead to a neuropathic pain. So what are the causes of the neurogenic pain? It can happen following a stroke, so post-stroke syndrome, or peripheral vascular disease where there is ischemia. It can happen because of compression of the peripheral nerve, spinal nerves, because of entrapment. It can have the spinal level. It can have peripheral levels, like little cutaneous nerve getting trapped under the fascia lata. So that is an entrapment syndrome. So it can happen because of degenerative process like multiple sclerosis. It can happen because of inflammatory process where there is sciatica because of the disc cannular tear and some inflammation happening. It can be secondary to infective process like post-herpetic neuralgia, Guillain-Barré, and it can happen because of post-traumatic this thing where there is surgery and trauma. For example, like ilioepigastric neuralgia or ilioinguinal neuralgia following the hernia surgery. Okay. It can happen because of toxic components, so alcoholic peripheral neuropathy or heavy metal poisoning can also lead to neurogenic pain. It can happen because of metabolic causes like diabetic peripheral neuropathy or vitamin deficiency. It can be because of autoimmune processes like the rheumatoid arthritis or SLE or panarthritis nodosa. Or it can be hereditary in conditions like Charcot-Marie tooth, where there's involvement of myelins there. So these are, you need to actually know, be able to list these causes. Okay. How do they present? The pain obviously can happen spontaneously. It can be burning, shooting, electrical, or formication. Okay. It can be evoked, so you can have hyper or hypoesthesia. You can have hyper or hypoalgesia. There is allodynia to thermal and vibrational sensations, and there can be nerve irritation signs on stretching. Okay. It can be referred pain from the spinal roots, plexus, or peripheral nerves, so you can have referred pain. Okay. There can be signs of nerve dysfunction, so patients can actually have continuous tingling, numbness, weakness, wasting of fasciculation, and it can also be associated with sympathetic overactivity. Okay, so these are all signs associated with neurogenic pain. The modalities of treatment basically can have patients on oral medications, tricyclic antidepressants like amitriptyline, anticonvulsants like pregabalin or gabapentin, which are calcium channel blockers, carbamazepine acting on sodium channels. Okay. Antiarrhythmic drugs like IV lignocaine, oral maxillatine, flecainide, tocanide. Okay, sodium channel blockers have also been used to some extent. Even simple analgesics, paracetamol, NSAIDs, or weak opioids can be used. Ketamine can be used, which acts on NMDA receptors, 30 to 80 milligrams per day. For certain conditions like herpetic neuralgia, you can actually use lignocaine patches, capsicane, 0.025 to 0.75% can be used. Okay, so this helps in depletion of the substance P, which acts on C fibers. And sometimes simple methods like barrier methods, like applying kiln flame around the areas which are hyperalgesic or hypoalgesic, okay, or hyperirritable, that can also actually help in the treatment of that. Lignocaine infusions have been used in chronic pain for a while. Somatic and spinal nerve blocks, epidural injections, steroidal injections. Intravenous guanethidine has been used. Continuous epidural nerve blocks techniques have also been used. And then we have stimulation like spinal cord stimulation or deep brain stimulation. These are advanced techniques. Spinal cord stimulation is like putting a pacemaker around the spinal cord. Okay, so that has also been used. So these are the various methods of treatment. So this is all. This is a question with just listing things. This is not very specific. So it's a very generalized kind of a question. Okay. And with this, we will end today's session, and we'll see you next week on Tuesday.